Good evening. I'm Hartford Healthcare's Tina Verona. Thank you so much for joining us for this live Facebook discussion. I am thrilled to be joined by Dr. Mark Alberts. He's the physician-in-chief of the Hartford Healthcare Ayer Neuroscience Institute. Dr. Alberts, it's a pleasure. Thank you so much for joining us.
Thanks for inviting me.
Absolutely. Well, we are going to be talking about new guidelines for the treatment of stroke. And this is such powerful information, Dr. Alberts, and it's a real life-changing, game-changer situation for patients with stroke. Talk to us about what these protocols actually mean.
Right, so these two new studies, Tina, are important because they extend the time window for treating people with ischemic stroke, which is the most common type of stroke that people have. Now we have an extended time window of, instead of 4.5 hours for these advanced therapies, they now go all the way up to 24 hours. So this gives us the opportunity to treat the worst types of strokes, and especially those strokes that occur in the middle of the night, what we call wake-up strokes. Somebody goes to bed normal, and then they wake up 7 o'clock the next morning with a devastating stroke. Before, a few months ago, we had no viable treatments for that type of scenario, but now we do.
So through this advanced rapid imaging that we have, you can clearly see this clearly defined criteria set of patients who could qualify up to this 24 hours of treatment with excellent results. And I do want to show an example here because I think this is valuable for people out there to actually see what you see that you can literally get after these scans in a moment's notice.
Right, so with this advanced imaging, which Hartford Healthcare has invested in and has pushed out to all of our major hospitals throughout our system, so if a patient comes in with a suspected bad stroke, they get this advanced imaging, which we call rapid. We do it rapidly, but that's not what the name really means. And as an example, we have two examples on the screen here. This is one patient, and you can see on this side, the purple brain is dead brain. We can't do anything about that. And unfortunately, in this particular patient, the purple brain and the damaged brain, which is in green, are pretty much the same, which means that there's not much salvageable brain. If the purple brain was smaller and the damaged brain, which is green, was bigger, then we would have an opportunity to treat them. Now, if you look at the next scan, this is a different scan on a different patient. This is somebody with a very small area of dead brain. You see a small area of purple, but a large area of damaged but salvageable brain, which is in green. So this is a very good profile. This is somebody that we can intervene on, go into their brain with a special catheter or a tube, grab onto the clot and remove it. And this patient has a reasonable chance of having a really good outcome because, again, the amount of dead brain is small, the amount of salvageable brain in green is big. But you have to do this advanced imaging, and then after this, for a patient like this, we would transport them to Hartford Hospital, which is one of the two comprehensive stroke centers in the state of Connecticut, and my colleagues would go in their brain, remove the clot, and fingers crossed the patient would have a good outcome.
And so these are two different patient scans that we're looking at that you showed those examples of, and this is what it's all about, patient selection.
Absolutely, and these are the tools that allow us to extend the treatment time window instead of 4 hours or 4.5 or 6 hours, up to 24 hours. And this is the real revolution of this, being able to intervene in these patients with a big bad ischemic stroke up to 24 hours after stroke onset. Not in everybody, but in select patients.
In a select subset of patients.
Correct.
And so this is really what is so incredible about this, is that typically you wouldn't be able to do anything for this type of a patient, for this subset of patients. You wouldn't, and now you can.
Correct. In the quote-unquote old days, which was a few months ago, we would have nothing to offer grandma or grandpa who woke up with a big bad stroke. But now we do. And again, these are the types of strokes that could put people or a person in a wheelchair for the rest of their life. But now with this intervention, with the screening, with proper selection, with treatment at a comprehensive stroke center, there's a reasonable chance, almost a 50-50 chance, that we can make them either all better or substantially better.
I mean, that is just incredible. And now these images, so we are a comprehensive stroke center here at Hartford Hospital. So these images, once they're taken, now if somebody presents to one of our other hospitals across the system, like Midstate or Bacchus in the East region, they have these scans. This goes to the stroke team here at Hartford Hospital immediately.
Correct. All of our major hospitals can do the rapid imaging scan in their communities where they are, and then the stroke team gets notified. It gets sent to our cell phone, and the pictures look just like this, so we can assist and advise the folks at that hospital, right, this is a good patient to come over here and get the intervention or not.
Right, and that is such a huge factor, because before you can't do that, and so now we have the rapid imaging to do that, and then obviously the treatment here at the stroke center. What have you seen so far in terms of the treatment here, in terms of patients that we can now help with this since we've instituted these protocols?
Correct. So first of all, we have done rapid on close to 150 patients. Wow. Just since the end of last year. So this is tremendous because, again, for 150 patients within our system of care, we can do this advanced imaging, better select which patients need to be transported here versus those that can stay at their local hospital. And we know that people like to stay in their town and in their local hospital. So this has had a significant impact. In about 20 or 30% of patients, they actually end up going to the cath lab, having the intervention, and more likely than not getting better, because we're selecting patients who have the ability to get better.
To get there. Just to clarify too, so we have the purple side, you said, which is the dead brain, and the green side is the damaged brain. Just for folks out there at home, explain sort of the difference. When does the dead brain occur? Is that the stroke itself? Right.
The dead brain, the purple brain, are parts of the brain that are permanently damaged. We can't do much to salvage them. Granted, we can do rehabilitation and normal medical care, but in terms of doing a fancy acute intervention, if the dead brain is huge and there's not much salvageable brain, we don't have much to offer those patients, unfortunately. But when there's a small area of dead brain and a large area of salvageable brain, those are ideal candidates to go in, remove the blood clot, and fingers crossed, they'll get a lot better.
We are talking with Dr. Mark Alberts. He is the physician-in-chief of the Hartford Healthcare Ayer Neuroscience Institute. We are talking about new protocols, new guidelines for the advanced treatment of stroke, and the results are just promising. We encourage you, if you have a question, please ask Dr. Alberts a question. May, of course, is Stroke Awareness Month, and I think it's important that we touch upon the symptoms of stroke, because not many people really take that seriously enough.
And a lot of people don't really know the symptoms of stroke. They think stroke is like a heart attack and you need chest pain, and you have to have chest pain, and that's not the case. So some of the key cardinal symptoms of stroke: acute onset of weakness or numbness on one side of the body, acute onset of trouble talking, getting your words out, understanding, acute onset of going blind in one eye or trouble walking. Any of those things that come on acutely, if there's no other explanation, it could be a stroke.
And I also want to mention, too, that, we are talking about these new treatment guidelines, which we have that 24-hour window. I do want to stress that it is so important still is time is brain.
That's true, Tina, because even with a 24-hour time window, in many patients we know, and the saying in the neurology world is time is brain. Right. So every minute somebody is actually having a stroke, the studies show that they are losing almost 2 million nerve cells. Right. Every minute. Wow. And I don't know about your friends. I don't have too many friends that can afford to lose 2 million nerve cells a minute. That's a big hit. When you put it in that context, I think that really can resonate with a lot of folks. That, absolutely. Oh my gosh, because you hear time, you hear the window, the 3-hour window or the 6-hour window. You hear that, but it doesn't. But when you say it that way, when you put it that way, boy, does that make you think. And even with a 24-hour time window, we want to image them and intervene with them as rapidly as possible within that 24 hours. Again, the extended time window gives hope, gives opportunity for those folks who wake up with a big stroke or their time of onset is unclear. But it's still true that time is brain. Yeah, we don't want people to think, oh, I've got 24 hours now that I can wait, and no. So we want to make sure that that is very clear. Prevention in stroke, and as we said, May is Stroke Awareness Month. Yes. So let's talk about ways to prevent a stroke. So again, our saying in the stroke community is that the best way to treat a stroke is to prevent the stroke. So when you talk about prevention, there are some things you can do something about, and there are some things you can't do much about. Age, as people get older, their risk of having a stroke goes up. We can't do much about aging. We don't have a fountain of youth yet. But there are some very treatable common risk factors for stroke. The most important, the most significant is high blood pressure or hypertension. Every number that your blood pressure goes up about 140/80, your risk of having a stroke goes up substantially. Get your blood pressure checked. See your physician or healthcare provider. Know what your blood pressure is. Get it treated. Take your medications. Get it under control. Smoking, very reversible, addressable risk factor for stroke. Diabetes, very common risk factor for stroke. Get your blood sugar checked. Take your insulin as your doctor or healthcare provider tells you to. Get your glucose down to a normal level. High cholesterol, very common risk factor for stroke. Eat a healthy diet. Exercise. Cut down on the meats and the fried foods. Eat more fish, more vegetables, more fruit. Healthy lifestyle can make a big difference.
What about genetically? If you have someone in your family who has had a stroke, could that be hereditary? Could that be something that you should be paying attention to?
Absolutely. Genetics does play a risk factor for stroke. Now, we can't do much about your genes, but if you do have a strong family history, then you need to get your risk factors aggressively checked. Your blood sugar, your cholesterol, your blood pressure, and you need to get them aggressively treated if they are abnormal.
What about, and I've read some articles like congenital heart defects, that if you have a hole in your heart, sometimes if there's a clot, it could travel up through there, up to the brain, and can cause a stroke. Is that?
That can happen sometimes, yes. It's not the most common cause of stroke, but it is common in relatively young people without other risk factors. So if you do have a history of heart disease, or especially what's more common than the hole in the heart, is atrial fibrillation,
I was going to say,
an irregular heartbeat. Atrial fibrillation is very common as folks get older. They get the devastating types of ischemic strokes that we would use the rapid protocol to diagnose and treat. And strokes in the setting of AFib can be prevented by using this new class of blood thinners called the NOACs, novel oral anticoagulants.
And mini strokes. We often hear of folks that have a mini stroke. They're called mini strokes, and they don't even know they had it, or they suffer maybe some slurred speech, and they go to the hospital and they walk out and they're fine. Obviously not a candidate for this. This is for a major stroke.
Correct.
So we want to make sure that we stress that.
But those mini strokes, as you identify, are risk factors for subsequent strokes. And it's sort of a warning, a shot across the bow that, hey, I had a mini stroke. That puts you or anybody at an increased risk for a major stroke. So what do you want to do? You want to check them for stroke risk factors. You want to do an MRI of their brain. You want to image the blood vessels in their neck. You want to get an ultrasound of their heart so that you can figure out what was the mechanism of the mini stroke, and then get the proper intervention, the proper treatment to prevent a recurrent major stroke.
You mentioned anticoagulants. Some folks take baby aspirin when they hit a certain age, and that is true for many people as an anticoagulant.
Aspirin is generally safe. It's generally well tolerated. Some people may need a baby aspirin, some people may need an adult aspirin, but aspirin is a pretty good blood thinner. It does prevent some strokes, certainly prevents heart attacks.
Yeah, Dr. Mark Alberts, thank you so much. This has been such great information. I hope folks out there got something out of it, because it really is life-saving, and we've come a long way in the treatment of stroke.
Well, we really have. 20, 30 years ago, we didn't have very many treatments. We didn't have good ways to prevent strokes. Now we have good treatments for many stroke patients, and we have excellent tools that we can use to prevent a stroke.
And we're doing it right here at Hartford Hospital.
And throughout our healthcare system.
Hartford Healthcare.
Yes.
Dr. Alberts, thank you so much. Always a pleasure.
Thank you for inviting me.
So thank you for joining us. If you would like to learn more about the Comprehensive Stroke Center at Hartford Hospital, or any of the stroke centers across the Hartford Healthcare System, you can call 1-855-HHC here. Thanks so much for joining us. I'm Hartford Healthcare's Tina Verona. We'll see you next time.